welcome to Scotonomics. Now, for our audience benefit, I'm just going to do a little introduction and tell them a little bit about you. So you received your BA from Harvard University in 2008. Prestigious. We know about Harvard over here in the UK. So, and your PhD is from the University of Pennsylvania, which you acquired in 2016, and an MD from the University of Pennsylvania in 2018. So that means in our terms, you're a medical doctor. And then also, you're both a physician and historian then, and your research focuses on the histories of health policy in Southern Africa and the United States. And you're currently a resident in emergency medicine at Brown University in Providence, Rhode Island. And your work investigates the causes and consequences of scarcity in medical and social service provision. Subjects of recent research for you have included international opiate control, population policy in Southern African politics, feminist critiques of national income standards, hepatitis C diagnostic techniques, and the contribution of medicine to population level mortality declines. So, you published No More to Spend. Do you want to tell us why you decided to write this book, Luke?
Yeah, absolutely. And thanks so much for the really generous introduction. And I'm really glad to be here. I've heard your show and I love your guests. And so I'm honored to be one. I wrote this book because I had spent time in Eastern and Southern Africa during and after my undergraduate years doing public health work. And I was really curious about why our standards were so different. Well, I was training for medicine in the United States, and I was used to training and practicing medicine a certain way. And then when I went to Malawi, I saw that my colleagues couldn't practice the same way. They couldn't intubate patients in extremis. They lacked some of the treatments that we take for granted here. And looking at the historical record, I saw more and more physicians, nurses, medical professionals who expressed this same sort of wonder and dissatisfaction that the standards of care that they had become used to when practicing in richer settings were never available to them, at least when they were treating Africans in Southern Africa. Sometimes it was different when they were treating the colonists, but never when they were treating Africans. And in some of the literature, it seemed like it was inevitable, like nothing else could be done. How could it be otherwise? This is a poor country. But then you look a little deeper and you realize that there's always more resources than you think there are. There's more money being spent sometimes on quite lavish things, but sometimes it's a little more subterranean. The money's going towards servicing debt. The money's going towards a loan guarantee that should never have been made in the first place. The money's going towards financing a war effort halfway around the world that seems very distant from the concerns of the populace. So I was trying to connect these two things, this sense of frustration in my own life and the lives of the people who I was seeing, with this sense that it might not be as inevitable as it's portrayed to be.
Yeah, I mean, you say some really interesting things about scarcity, and this is something that I think that this mythology is deeply embedded into the UK as well. So how you state that scarcity was one of the most common ideas in official correspondence and public proclamations, and that the scare of scarcity has led it to becoming a powerful political tool. And as I say, I see this repeated in the UK, and that we too in the UK have become socialised for scarcity, in that many believe poor outcomes are actually inevitable. And that includes healthcare providers and policymakers. Interestingly as well, when you bring up Malawi, this is particularly interesting for us in Scotland because we have a deep relationship with Malawi through the David Livingstone, a well-known son of Scotland. But you also make this other assertion, which I think is going to click with many people, that part of the mythology was the colony being sold as the protectorate. And that's a really interesting concept as well, to go along with you know, the scarcity. It's this, the fear, the protector, the fear, the protector. Do you want to comment a little bit more on that?
Yeah, absolutely. I mean, I spent some time in Edinburgh doing research. Some of the premier historians of Malawi were Scottish: George Shepperson, John McCracken. You know, the links are, like you said, David Livingstone. The links are manifold. And every time I got on a plane, it was just all wherever I was getting on, whether I was getting on in Kenya or South Africa or London, it was always Scots who I was sitting next to. So I was really happy to hear of your interest in this as well. But yeah, absolutely. I think that those links are definitely true. I mean, I think Malawi shows things in extreme form in how these dynamics play out. But you know, in reading about the NHS today and how you know, how the budget's not sufficient to treat people, and the comments about scarcity being made in the British context, in the UK context, that definitely jobs. It definitely makes sense. You know, this notion that Malawi should be grateful for whatever it's given is really powerful and holds throughout the years. I mean, ever since Cecil Rhodes, you know, said that he was going out of his way to just to form this protectorate, you know, and had the chiefs sign the protectorate paperwork at the point of a gun. You know, that language has been there ever since. So, you know, it's amazing how the language of protectorate, of aid, of dependence has always been used to make Malawi seem like it must be the beggar, even as it's spent so much of its resources, you know, helping to line the pockets of Belgian financiers and you know, Whitehall administrators. So it is a powerful way to make people feel less than.
So with this, you know, I had a little bit of a conversation with you online about Cuba. So we know famously that Cuba exports doctors, and Cuba is not a wealthy country. So what's going on with this? So today I got a little bit more research into what's going on in the UK. Now, it's the UK Medical Schools Council that released this information. So they released a paper in February 2021, which stated that there were 28,690 applications for medicine. But the number of places available to study medicine in the UK are 9,500. Now, look, I experienced this situation personally when I graduated. I graduated when I was 48, alongside people who were in their 20s. And a number of them, because I did a life sciences degree, wanted to go further and take their life sciences degree and do medicine. That's what they wanted to do with it. And I'm talking about young people who were very clever. They were getting firsts and they were well socialized as well, which I know is something that's important when you're applying for medicine. So, you know, as I went on to understand about government finance, it became obvious to me that this was a real resource that was not being utilized by the UK. And it really is just so distressing when you understand that currency is not the constraint. You know, our constraints are with real resources. And when you know that a real resource is out there and it's not being utilized, this becomes even more distressing as well. So they published another paper in October 2021. They realized another report which states that the UK NHS is under threat because the workforce is not growing enough. So moreover, the report states that the UK has never produced sufficient numbers of doctors to be self-sufficient. And international graduates can and will continue to make an outstanding contribution to patient care. So therefore, not only are we not educating enough of the kids in our country who want to be doctors, the UK is also then pulling in doctors from other countries who probably need them even more than we do. So they're plundering real resources from other countries as well. So, and moreover, the report states that more international graduates join the GMC specialist register every year in the UK than UK graduates. So not only are we not in a position to send doctors abroad, we're pulling doctors in from abroad as well. Are you shocked to realise that?
No, sadly, I'm not. I mean, this question of brain drain, as it's been called in the global health literature, has been around for some time. I mean, it's been known that, in some American cities and cities in the UK, you'll find more nurses, more doctors from certain African countries than in those countries themselves, and that it is an opportunity for those particular individuals to gain a much higher salary and a better living for their children than they might have otherwise in their own countries. But so many of them don't want to leave. They don't want to leave their homes and their children, but they see no other choice if their own healthcare systems are hollowed out and there's no good jobs for them there. But it does leave us in the situation where we being the global north in the US and the UK, rely on training institutions in Malawi and Ethiopia and Kenya to train the nurses and the healthcare workers and the doctors that are going to staff our institutions. That seems entirely backwards. And yeah, as you said, part of the problem is that we restrict the number of training institutions and residency slots in the United States. Part of that's the medical lobby in the United States, at least in our case, that's done that to as a deliberate attempt to restrain the supply. But there are certainly other factors, and scarce, this argument about scarce medical resources is certainly one of them. People in the United States, when they graduate from medical school, graduate with 6 figures of debt, and they spend a lot of their early years trying to pay that off, and in trying to do that, they end up trying to go into the most lucrative specialties, and that leaves this huge swath of GPs, as you call them, the slots wanting. And so a lot of rural areas end up begging for foreign graduates to come fill those spots and paying people to come live in their area. So it's a complex interdependence of all these different pathologies coming together that creates kind of the worst of all possible worlds for everyone. And it's really becoming more acute with every passing day in the COVID pandemic. The doctor shortage, there's not really as much of a doctor shortage, although doctors are leaving the profession out of a sense of frustration and burnout. But nursing is just really dire right now. And I think this impetus to import nursing graduates is just going to become even stronger as the year goes on.
You also bring up a really distressing story in the introduction as well about Innocent, and he is shot. He's a young boy. He's shot in his leg, and his popliteal artery, which is for the audience, is artery behind your knee, is damaged, and it's quite a simple operation to fix it, but there's no vascular surgeon anywhere close to where he is at all. So subsequently he goes into hospital, the leg becomes gangrenous, and the lower leg has to be removed. Now, this is a young boy who's living rurally. There is no possibility that he can go about in a wheelchair. He's going to be in crutches for the rest of his life. And this is an acute example of this nonsense of scarcity and its damaging effects. That the authorities in many countries, not just the UK and Malawi, in many countries, convince the polity that there's a lack of resources. And what I've just said earlier on is there's not a lack of resources. The resources are there. It's that the governments are not cultivating them.
Yeah. I think I use that story as an example because I think that when we talk about global health, a lot of the focus ends up being on the kind of low-hanging fruit, the basics that are still wanting. The vaccines, the latrines, the basic primary care that we know saves millions and millions of lives. I mean, oral rehydration solution might be the biggest medical intervention aside from vaccines that's ever been invented, and saves tens of millions of children over the last few decades just from diarrheal disease, from preventing them from basically desiccating to death, you know? So that stuff's very important. But then you get to something like Innocent's case, shot in the leg by the police after happening upon a protest against land alienation. Young boy ends up shot through the popliteal artery, and because there's no one there to do the graft surgery that would save his leg, he has the artery ligated and it slowly dies, as you said. That is a surgery that is so simple. It's been around since the Korean War. Not everyone has their limb saved. It's a dangerous thing to have happen to you, but most people in the United States who come in with that injury would have their limb saved. But if you mention that in the global health circles, even people who do this for their living and believe in the cause, they will say, that's not the first priority. That's not the second priority. That'll happen someday, but certainly no day soon. And it's that sort of nihilistic thinking, that sort of assumption of an impoverished imagination that has really plagued global health for so long. And I'm not even just talking about the IMF and the World Bank and the structural adjustment era. I'm talking about people practicing now in the present day, and that sort of impoverished imagination really does lead to this thinking that we can't hope for more, but fighting for the very basics for the foreseeable future. And that sort of thinking actually was overturned briefly in the era of the AIDS pandemic, when people said, you know what, antiretroviral for HIV, they cost $10,000 per patient per year. They don't have to. We can get them for cheaper. We can get them now. We can save people's lives, and we don't have to wait. There's no need to wait. There's no need to let millions die for the sake of, incrementalism. And they didn't. And millions didn't die. I mean, millions did, but millions were saved as well. And I think we need some of that spirit back again. It has petered out, unfortunately, and we need some of that spirit back in order to make sure that we don't fall into the old ways.
When you were in Malawi, did you feel yourself, there is actually much more of an abundance of resources to deal with this issue? It's just that the government is not spending the money on this. Did you feel that?
Yeah, I mean, I think I wanted to point to a few actors. One is historically, one is the government. I mean, under the Hastings Kamunzu-Banda era, a doctor trained in the United States who worked in London and then came back to Malawi as this figurehead president who became president for life. He ended up, spending a lot of the resources on his own palaces, on building a new capital city, on all sorts of things that weren't, helpful to the populace. But when I was there, and even now, I mean, the president now, Lazarus Chakwera, he's born poor. And what a name, Lazarus. He has proven to be a pretty dedicated public servant. And there have been others in recent Malawian history who have tried to devote more of the government's resources to health. But it is true that, for some institutions, scarcity is a real thing. And for the Malawian government, especially right now, with interest rates being what they are, Malawi's devoting about a quarter of its revenues to debt servicing. The dollar's strengthened, the Malawian kwacha has weakened. Food and fertilizer have scarcely been more expensive. One of my friends sent me a WhatsApp the other night from the village where I was doing research, and he said, I'm literally starving right now. We had to arrange to get him some money to buy some food for his family because of the price of food currently. So I think all that to say, I think the Malawian government does face some limits on its spending. They're not of its own making, and they're not, and it's not the only one who should be held responsible for this. I mean, should Malawi be left, after all of the history, after all of the resource extraction, after all of the exploitation, should Malawi be left to its own devices at this moment when food and fertilizer are at record levels because of external forces, because of Fed policy, because of the war in Ukraine? This is not the moment to say no more can be done. And fortunately, there are voices, some powerful voices, saying that more should be done, more can be done. But this is Malawi cannot stomach this kind of rhetoric right now. Even if the government tried to do as much as it could, it would not be nearly enough.
I wonder if for us you could go through the different reaction in Malawi to COVID and the USA to COVID. What did it feel like to you, and how did scarcity play a part in that?
Yeah, in many ways. I mean, first even knowing the status of COVID in Malawi and in Africa generally has been a tremendously difficult thing. How common is COVID in Malawi? It was hard to know because the tests weren't readily available, they weren't produced there, they weren't shipped there, they were being really bought up by the United States and the EU. They were hard to find in Malawi. And then vaccines were the same way. Pfizer and Moderna would not share the technology that was used to make them. They were insistent that the IP was theirs, even though it had been developed in government-sponsored research. And so when I was visiting Malawi late last year, about 5% of the population had received their first dose, even as 70, 80% or something like that in the United States, and most European countries had received theirs. So it was hard to know how much Malawi was being affected, who was being affected, and it was also hard to know, how people would ever be protected against it. And the people who I met, the ER doctors who I work with there, they saw plenty of COVID. They had a tent set up. They still had a tent set up outside the hospital where they put their known COVID cases, and plenty of people died. Excess mortality in Eastern and Southern Africa has shown us that people were dying in tremendous numbers of COVID and of COVID-related causes, and continue to do so. But the knock-on effects of COVID perhaps have been even worse. The supply-related constraints that have pushed up inflation around the world, and that have led to constraints on very necessary goods in the United States. I mean, we ran out of IV contrast to do CT studies in the United States, but in Malawi they were running out of a whole lot more than that. So it's really been a question of two things. One is COVID itself, which took a tremendous and still untallied toll, and the second is the knock-on effects of COVID, which we've really turned inward. We've really focused on what it's doing to us, what it's doing to the US, what it's doing to the UK, and there's been plenty to talk about. But I think that's been to the detriment of much of the rest of the world, including Malawi, still the poorest peaceful place in the world. We've really turned our attention away from there, and they felt it. When the US catches a cold, Malawi truly does get the horrible case of pneumonia, and that's really happened there.
Yeah, I mean, another consequence, of course, with us in the UK, we had 10 years of austerity before. So we've had a Conservative government since 2010. And of course, their raison d'etre is small governance. And obviously, they want to spend as little public money as possible, or rather, they want to spend as little public money on certain things, being healthcare, for example. So the pandemic was gamed here in 2017, and they decided not to do the deficit spending, to buy the PPE. And of course, as we all know, the PPE became incredibly difficult to source when we had COVID. It became a lot more expensive. So there was just no preparation for it at all. Subsequently, we lost 650 medics in the first year of COVID, because they had no PPE to protect them from this nefarious virus. This is another example of a scarcity that didn't exist. The scarcity did not exist. Our country has its own currency. It could buy those things with that currency. It chose not to. And, of course, you would have had the same situation in the States as well, I would think.
Yeah. I mean, I guess there was a moment last year, and you guys talk a lot about MMT and the possibilities thereof. And there was a moment last year when people started questioning these notions of scarcity and deficit spending, and how, does everything really need to be like paid for in the moment, in that bugaboo of public discourse in the United States? But that really has changed, unfortunately, and there is just so much more that needs to be done in the United States. But to return to Malawi one more time, I mean, even macroeconomists, the same macroeconomists who are like blaming deficit spending for the rise in inflation currently, like Larry Summers and others, they'll be the first to admit that the sums of money that we're talking about when you want to make healthcare much more decent in a place like Malawi are so small that it's a rounding error in macroeconomics. Jeff Sachs used to like joke at these. I saw him once at a tropical medicine conference, and he said, I'm used to talking in trillions. You guys are talking in the tens of billions. This is such a, like, it's not a joke because it kills people, but it's a joke because like we're talking about such small sums of resources for such outsized effects that it seems silly to macroeconomists that we're spending so much time, wringing our hands over this so few resources, because it could be solved so readily. It's if we could imagine just a little bit more broadly, then so much more could be solved.
Yeah, completely agree. And other lessons you want to bring to our audience?
I think that there are a lot of parallels that we can see in the present moment, and some of the episodes in the book. I'll talk about one. I mean, the early 1980s, the Volcker shock of the early 1980s, when interest rates in the United States and elsewhere went up very quickly in response to some external shocks. That had knock-on effects around the world, including in Malawi, where a confluence of disasters occurred at the same time. The oil shocks, drought, rising interest rates, and demands for austerity from the International Monetary Fund and the World Bank basically caused a collapse in the health system. If it was poor to begin with, it was truly impoverished thereafter. And the doctors who wrote in the 1980s and 1990s make some of the most dismal reading you will ever see. I mean, they're talking about running out. No, we have no gauze, like gauze to cover a wound. Like they said, we are mortuary attendants at this point. We are not doctors. So this kind of, we should be very, very cognizant that however necessary or unnecessary the specific moves of the US and the EU are right now, we should know that they will have huge, huge effects on the global poor. And if we do not address them, that the doctors and patients in Malawi are going to feel it way, way harder than we ever will. So I beg of the listeners, I beg of our policymakers, like, a penny of just a little bit of thought towards the effects of what we're doing on around the world.
Yeah, I mean, fundamentally, we could be educating many more doctors in the UK and probably in many other places like the US, and we could be exporting them just as Cuba does. And that would be us sending out a real resource to the poorer parts of the world.
Yeah, when you mentioned Cuba, I looked it up, and they do indeed train more doctors per capita than anyone else in the world. And they're not a rich country, but they do provide educational opportunities for promising students in a way that other places don't, that we certainly don't. I've met so many bright young students who want to be doctors, and who want to be doctors for the right reasons, who want to be nurses for the right reasons, who want to be healthcare workers for the right reasons. They really do have a heart for the work, and they're never able to pursue it because it costs too much, because there just aren't the spots available, because, like you said, they aren't socialized in quite the right way. This is a tragedy of wasted resources, and it's not just here. I mean, I've met so many people in Malawi who are promising, and to get into Malawi medical school, you have to be a true genius. Like they put us to shame with their work ethic and their abilities. So yeah, like you said, there's so many wasted resources, and part of the reason is because we've come to believe this rhetoric of scarcity.
I mean, look, it's fascinating hearing a doctor talk about interest rates, because normally the only people who know about interest rates, talk about interest rates, are the usual type of person we interview in Scotonomics, which is an economist. But you've highlighted one huge issue, is that the interest rates draw money, especially to the States, when the dollars, when the interest rate's high at the Fed, it draws dollars not only from economies who have got that money to spend, but it also pulls in that money that needed to be paid for interest. So the higher the interest rate, the less amount of money circulates in these the poorer economies. And this is a huge global issue. And I do know that one of our guests, Claudia Sam, who used to work for the Fed, has been talking about this, for a long period of time, just to try and get the realization that these policies have a big impact. So it's fascinating to hear you talk about that. I've got one specific question around colonialism, though. And I'm wondering if you're aware of, we interviewed her just last month, I think, Professor Gurminda Bambra. I'll forward you on a paper that she wrote, because it's fascinating, and it basically says that the welfare state in the United Kingdom was only born out of the resources that came from the colonies. So what impact do you think this kind of history of colonialism and the change to another form of colonialism, we won't call it post-colonialism, but where we are now, what impact does that have in Malawi?
Yeah, I think the welfare state question is always really fascinating to me. There have been some good works, but I think there could be so many more. So I'm excited to see this one. There was this moment in the 40s, when the beverage plan came out. The beverage plan wasn't just popular in the UK. It wasn't just a bestseller in the UK. It was like a global phenomenon. And in Africa, there was a spate of work, in and around it, not just inspired by it, working around it, to say that this should be a global beverage plan, right? Like, we all contributed to the war effort. Like the Malawians were sending their tax revenue way back to the UK to pay for the war effort. They, during the World War I, during the First World War, they were fighting in East Africa. So like the Malawians had long experience with fighting the UK's wars, and they thought that this product of wartime solidarity could be theirs as well. And unfortunately, some voices within the Labour Party were saying, we cannot afford to let this happen elsewhere, to say that healthcare as a right should be extended to the colonies as well. And part of the explanation they had was that the average British voter just wouldn't stand for it, and then they'd lose elections. So they thought it was politically disadvantageous for Labour to have a more cosmopolitan vision of what could be done. So unfortunately that way of thinking has continued, and yeah, we've restricted our view of the possible to within national boundaries, or even further, unfortunately. So there is I think I look at that moment of the 40s, that moment of the creation of the welfare state, the moment of William Beveridge, who actually did a lot of his initial work, or in work after the Beveridge Plan in India, trying to see how India could institute more social policy as well. That was a moment of possibility, but unfortunately it was a moment that was unrealized. But as your previous guest said, it was a moment that was only possible perhaps because of the resources extracted elsewhere. But at this point, certainly, the world could afford to do so much more, and to make that long delayed vision a reality in more places.
Yeah, and moreover, in the UK and in the US, again in the Netherlands as well, where I lived, these are all well-known tax havens, and they practice tax havenry. So it's pull resources from other people and stash the cash in a safe place where a lot of that cash is just sitting doing nothing. It's not helping people to exchange goods and services with each other. And this is tragic, and we have to help more and more people understand this. I think in the UK right now, and I don't know how this is affecting the US, we have an energy crisis. And, a lot of people around about me now are starting to see, well, hang on, don't we have oil fields here? Don't we have huge amounts of renewable energy in Scotland? Why are we paying so much money for energy when we have so much resource? It's well known that we have this resource. So I think people are starting to think about real resources now, because this is a very important resource, energy, for any country as well. And especially if you're living in a cold climate where you need the gas in the winter to keep warm. We are concerned here in Scotland that we will lose a lot of people this winter, just because they'll be too cold in their houses and they can't afford the heating. So yeah, I think, I hope that more and more people are starting to understand this difference between a currency and a real resource, and that a currency is just a tool really to move and create those resources. Do you think there's a change, certainly in your profession, of understanding that? What about the people round about you? I mean, obviously very well educated people.
Yeah, I hope so. There is definitely a move within medicine to have more training in what's often called social medicine, and understanding the root causes of illness. Cold weather kills many people, and it's not just the cold, right? It's the cold married with an inability to heat your home, and the forms of want that lead to that. So that it does demand of us a deeper study of many different subjects, economics included, history included, which, to be honest, is a little bit of a it's a controversial thing. I mean, there are people. The person who taught my health policy course at my old alma mater for medical school subsequently wrote a bunch of op-eds in the Wall Street Journal, railing against woke education of medical students, and saying, we need to just focus on the biochemistry and the biology. None of this other stuff. This other stuff is really just superfluous and outside of the realm of medicine, and it should not be seen as part of medicine's remit. But I beg to differ. I mean, when my patient comes in with frostbitten feet, I want to know why. I want to know what am I to do to warm their feet and to send them right back out until they fall off.
Yeah.
So that effective treatment of medical conditions does demand of the doctor a deeper understanding of why the patient became ill to begin with. And this is as old, this is 19th century social medicine. This is Rudolf Virchow and others who said the same thing. So we're not breaking new ground here. We're just finally recognizing the wisdom of old.
Yeah, there's an epidemiologist who started off as a GP called Michael Marmot, who did a famous study here. You know about it, obviously. But, there was another example that just came to mind. When I was doing my degree, I used to read a lot of medical biographies. I found them quite entertaining and educational at the same time. And I read the biography of an American woman who was a neurosurgeon, and she was doing placements all over the US. One of the placements she did was in the Blue Mountains of Virginia, which has very, very poor areas. And she talked about this patient that was brought into the hospital. And this is as bad as Innocent's story. So he lived up in a cabin in the mountain, very poor, and he got an infection just above his eye. And all he did was wrap a bandage around it, and he left the bandage on. And, after a certain amount of time, he had to go down to the village and go and get some food. So he went to the local store. When he was in the store, the people in the store decided to phone the police because he smelled so bad. He smelled so bad because the infection had drilled its way through his skull and eaten into his eye. It had destroyed his eye, but not only that, it destroyed part of his frontal lobe. So he's no longer a functioning human being, and he would require care, quite serious care, for the rest of his life, for the want of some cheap antibiotics. Not even an operation, just some antibiotics. It's a shocking story in a country where the people have, we've from Scotland, from Ireland, from Europe, we've all gone over to America. We've, picked up all these real resources in this huge country, but we can't share. And we have to.
It's enraging is what it is. It just makes you apoplectic. I mean, it's almost beyond words, to be honest. I mean, yeah, and I'm just, the more I think about the problems facing your own neck of the woods right now and the rising energy costs. I mean, I can't say I'm a huge fan of Liz Truss, but do I hope this plan to make sure people can afford energy costs works? Like, yes, I do, but I worry so much that if people can't afford the basics of living, that they're going to face such dire consequences. And these horrible anecdotes will just become more frequent.
Look, it's been fascinating. I've absolutely loved that conversation with you. Thanks so much for joining us.
Thanks for having me. Thanks for your work, your work to make us reimagine the possible. And I look forward to your future conversations.
Look forward to your next book.
Thanks.
Thanks, Luke. Bye for now.